Thank you, chairpersons. And at the outset, I would like to thank Dr. Arun Gar for inviting me to deliver this talk. And my topic today is frontotemporal dementia, which is a commonly misdiagnosed entity. And as we go, first of all, we need to understand frontotemporal dementia is an underdiagnosed group of neurocognitive disorders, and it is the second most common degenerative dementia and neurocognitive syndrome that presents with impairment of changes in behavior. So behavior is very important, followed by executive dysfunction and a decrease in language proficiency. These are the three main components of diagnosing the frontotemporal dementias. And there are lot of diagnostic challenges associated with FTD, and therefore the true prevalence is likely to be underestimated. A number of psychiatric and neurological disorders resembles the spectrum of the FTD symptomatology and may contribute to misclassification and underestimation. This is what we are going to discuss today. And as far as the recent advances are concerned, it suggests that there is an array of potential novel new therapeutic agents which are in pipeline for therapeutic benefit of these patients in the coming years. So we all know there is degeneration of frontal and temporal lobe in frontotemporal dementia, the name suggests. 3 to 4 people for every 100,000 people have FTD. Common cause of dementia in people under the age of 65 years. And the similar incidence of Alzheimer's disease in this group also. And it is the one of the commonest differential diagnosis when the patients of FTD comes to us. And the important thing is 40% of the patients are familial. So it is very important to take the history of family members for when we assess these patients. And there are three genetic factors for frontotemporal dementia, that is C9orf72, GRN, and MATP. Because we need to understand these genetic polymorphism in these patients, because nowadays the therapeutic basically is dependent on these genetic polymorphism. Now, coming on, the mean age of the onset is 52.8 years. There is male preponderance, and the prevalence of AD and FTD in the age range of 45 to 64 years is same, that is 15 per 1 lakh. So FTD and AD are almost commonly prevalent in a practice. Now, how to diagnose and what are the criteria which we should not be missing when we see the patients of frontotemporal dementia? There are a lot of new criteria which have come up, and we have been having the criteria since 1994. But I need to emphasize here, diagnosis is still obtained clinically due to the absence of definitive biomarkers. So your clinical history needs to be very relevant to the symptomatology of the patients of FTD. The first research criteria came in 1994, and recently we have the internal consensus criteria for behavior variant of FTD, which is around 88% sensitive. Now, coming on to the main clinical features of the different presentations of FTD. FTD is basically heterogeneous, and FTD presentation can be with other neurological disorders, like with PSP, we can have the FTD symptoms. With corticobasal syndrome, also we can have FTD presentation. We have three main FTD presentations, that is behavior variant of FTD presentation. We have logopenic variant, and we have non-fluent agrammatic variant of frontotemporal dementias. I will be going in details of these in my subsequent slide. And a very common major presentation is FTD with ALS, which we should not be missing. And a lot of the young patients who are presenting with ALS, you should always be doing the higher mental functions to know about their cognitive status. Now, coming on to the pathological association. FTD is basically categorized into tauopathies. We have a lot of tauopathies. So when we talk about the pathological association, we have tau 4R, we have 3R. This is basically the pathological classification, and I will not be going into the details of these pathological classification because it is little complicated. Now, coming on to understanding as a general neurologist or as a student, what are the basic component or basic criteria for defining the behavior variant of Frontotemporal dementia is disinhibition, apathy, altered eating habits, stereotypic attitude, and dysexecutive syndromes. We should be having in mind all these symptoms if the patient you are uh, having behavior variant of frontotemporal dementia. The other variant is semantic variant of primary progressive aphasia, in which you have to be very meticulous in understanding the language pattern of the patient. They can have a semantic paraphasias, circumloculations, they can have having anomia, and they can have loss of meaning of the word. They will not be able to understand the meaning of the word, and they will not be able to name, and they will not be able to tell them what the particular object you are showing them does. Another variant is a non-fluent variant of PPA, in which the speech will be very labored. The patient will be having a speech in which the patient will not be able to speak the single sentence or a single word. There is reduced speech output. There will be a lot of grammatical mistakes, and there will be apraxia of speech. And in another variant, which is a new variant, that is right temporal lobe variant of FTD, in which we have a lot of behavioral issues. These patients are basically obsessive. They have spatial disorientation. They have prosopagnosia. It means they will not be able to recognize the faces shown, and anomia. Now, coming on, as we know, there is critical heterogeneity and overlap of other neurodegenerative and psychiatric syndromes because of lot of behavioral symptoms in these patients. And there's growing recognition that FTD shows significant clinical, pathological, genetic overlap with number of movement disorders like PSP, CBS, and MND. Now, the important thing, which is basically why we are not able to diagnose the FTD timely, is because of the marked social and behavior changes that are common in FTD spectrum disorders, alongside the relatively young patients. They are young patients. The onset is early. Clinical presentation of these neurodegenerative disorders may be mistaken for psychiatric illness. So most of the patient, because of the presentation of the behavior symptoms, they go to the psychiatry, and they are primarily being diagnosed as a primary psychiatric disorder. Now, as far as psychiatric and neurological overlay is concerned, in almost all the neurodegenerative disorders, we have a lot of overlay of psychiatric symptoms as well in all our neurodegenerative disorders. So the FTD patient experiences initial psychiatric diagnosis significantly more frequently than the patient with other dementias, with estimated 50% of the FTD patients receiving initial psychiatric diagnosis compared to 23.1% in Alzheimer's disease. So FTD patient, because of the behavior symptoms, usually have the psychiatric diagnosis first, and later on the neurological diagnosis is concerned. And the diagnoses which are made are basically major depressive disorders, because of the apathy is one of the major symptoms. And bipolar affective disorder, sometimes the frontotemporal dementia patients have maniac behavior, so they sometimes be diagnosed as behavior affective disorder. And schizophrenia, one of the common psychiatric disorder, is also being very closely related with the symptoms of the FTD. So, in schizophrenia and behavior variant of FTD, they have negative symptoms, that is apathy, and occasionally they have positive symptoms, that is hallucinations, which are reported in minority of the patients of FTD. So, we have to be very clear in classifying the psychiatric symptoms. And here I would like to emphasize, we have to have a team with psychiatrists also, so that we can delineate these symptoms, whether it is falling into the category of psychiatric symptoms or that is because of the neurodegeneration. Now we know it is the second leading cause of neurodegeneration. And again, to emphasize, behavior changes, social conduct, emotional processing, and executive dysfunction. These are the four major components of diagnosing frontotemporal dementias. Now, as we know, we are not able to diagnose these patients timely. And in this series of our patients of 1876, which we have published in 2017, and as I've told you, the frontotemporal dementias and the Alzheimer's disease are neck to neck. The prevalence is almost same. But in this series, we were only able to reports 7% of FTD patients from our center. Possibly because neuropsychiatric center, most of these patients are in follow-up with the psychiatry. So we were able to only report 7% of the patients of FTD in this series. Now, the behavior symptoms in the patients of frontotemporal dementia, in this series of 7% of the patient, we have all the behavior symptoms present in a patient, from depression to apathy, and the main symptom which was there, 19%, was disinhibition. So we can have all the behavioral symptoms in a patients of frontotemporal dementia. So it is always advisable to evaluate the patient for different behavior symptoms in frontotemporal dementia. This is one of the major concerns. The young FTD patient with prominent personality changes and behavior abnormalities to receive an incorrect initial diagnosis of primary psychiatric disorders, which often happens, such as schizophrenia, bipolar disorder, and major depression, with FTD only becoming recognized as the disease progresses, and patient usually comes to us in 3 to 5 years of duration. Now, this is one of our patients. He is 49-year-old right-handed businessman by occupation, as well as he was singer and decorator. There are no comorbidities, and he presented to us with complaints of change in personality and behavior since last 1 year, abnormal gait since 7 to 8 months, and difficulty in speech since last 5 to 6 months. And you can see this patient.
अंकल जी यहाँ देखो, ठीक है, नाम बताओ.
He was very apathetic, and he went to psychiatrist for consultation, and he was into the follow-up of psychiatrist for 8 months. He was given risperidone, he was given escitalopram, and he was given
अंकल यहाँ
THT.
देखो.
And because of the antipsychotic drugs, this patient has actually developed the extrapyramidal syndrome, and he was very bradykinetic when we saw this
अंकल पेन
patient.
रखो यहाँ, पेन
And
रखो.
when we further evaluated this patient, this was his MRI. The MRI is clearly showing the frontotemporal atrophy, and that to be in favor of behavior variant of frontotemporal atrophy in prefrontal area and anterior temporal region, anterior cingulate, and striatum and thalamus. So the structural MRI is quite diagnostic of this patient is having frontotemporal dementia, and there was a lag of 8 months before he came to us. Another diagnostic challenges, there's misdiagnosis of FTD have recently been identified as one of the top sources of burden to caregivers, because they keep on taking the patient to different psychiatrists. Initial psychiatric misdiagnoses are associated with significant delay time in accurate diagnosis of FTD, anywhere between 3 to 6 years. This is. And the risk during the delay period, including inadequate and incorrect prognosis and medications like antipsychotics in our patient, wherein he has developed the extrapyramidal syndrome, ineffective symptom management, increased clinical visits, and increased caregiver burden. Now, the diagnosis of behavior variant of FTD remains challenging because of absence of biomarkers, and therefore relies predominantly on the clinical assessment. So here we have to emphasize on the behavior symptom of the patient to categorize them. The behavior symptoms is due to the psychiatric illness or due to the neurodegeneration and dementia. And the symptomatic overlap with neurodegenerative primary psychiatric disorder, including major depressive disorder and bipolar disorder. Now, around 50% of the patient with behavior variant of FTD receive the prior diagnosis. This I am again emphasizing. Average diagnostic delay is 5 to 6 years. It is also common for the patient with primary psychiatric disorder to be wrongly diagnosed as behavior variant of FTD. This also happens, particularly in community setting, preventing patients from assessing evidence-based psychiatric treatment. Now, with this bipolar disorder, which is a common diagnosis in the patients of frontotemporal dementia, we need to remember it is a highly disabling condition characterized by periodic mood changes, euphoria, and dissemination. While in FTD patient, we don't have periodic mood changes. We have mood change. We have a stable behavior problems in a FTD patient, while in these patients, they have periodic changes. The core criterion for diagnosis of bipolar disorder 1 requires manic episode, whereas the depressive and at least one hypomanic episode is needed to be needed to diagnose behavior disorder, bipolar disorder XS2. Now, there are some recommendations how to differentiate the behavior changes in FTD versus the behavior changes in FTD. So, minimal requirements clinically assess the behavior. Clinical recommendation is systemic use of the behavior scales and the psychiatric scales. And now, this is an important slide in which there is, we know there is overlap in the behavior symptoms of psychiatry as well as in dementia, but they have done a meta-analysis for knowing the neuroanatomical substrate for both the disorders. And what they had found was the gray matter volume in prefrontal, anterior cingulate, temporal lobe, and amygdala and insula. They are common in both psychiatric disorder as well as frontotemporal dementia. So the anatomic localization is same, and the clinical presentation, the clinical phenotype is also same. Now, another variant that is primary progressive aphasia, another type of frontotemporal dementia. It is a simple approach. You have to meticulously take the history of the language dysfunction. I will just like to show you how she is speaking. I think it's not working. Okay. This is not working. So this, yeah. Audio? Can we have audio? This is how the patient of primary progressive aphasia
बिल्किस बना
speaks.
अपने बारे में बताइए
They will not be able to speak the simple
बारे में
sentence
बताइए।
or a word. This was her PET scan, which shows there was hypometabolism in anterior cingulate frontal cortices, and it was consistent with advanced frontotemporal dementia. So, assessment of language is very important in delineating the different forms of primary progressive aphasia. Another thing which is a diagnostic dilemma is FTD phenocopy, which is a very slowly progressive frontotemporal dementia variety, and for which the biomarker which is now being in investigations is neurofilament light chain. And as for other degenerative dementias, we have biomarkers. We are having a biomarkers for frontotemporal dementia soon in form of fluid biomarkers, CSF biomarkers, neuroimaging biomarkers. And biomarkers are in differential diagnosis is very important to differentiate it AD from FTD, because the AD profile will be different from that of the FTD profile. AD will be having A beta 42 reduction and tau increase, while this is normal in patients of FTD. Now, my final two slides. The challenges in diagnosis and prognosis. The early diagnosis is crucial in providing patients with their family with useful information about the disease, avoiding unnecessary and inappropriate treatment, selecting patients for relevant clinical trials. With application of revised clinical criteria, distinguishing FTD from other common neurodegenerative and psychiatric conditions still remains challenging. The clinical subtype PPA may be difficult to distinguish from one another and do not consistently predict the underlying FTD versus AD pathology. And the final thoughts, what I want to say is, frontotemporal dementia should be considered in adults aged 50 to 75 years presenting with behavior and language dysfunction. When frontotemporal dementia is suspected, the other causes of symptoms such as psychiatric illness or psychiatric diagnosis should be considered. Functional disability occur within 3 years of diagnosis, but variable between patients. Like in FTD phenocopy, they can go long for 10 years. Multidisciplinary approach care assists in diagnosis and in addressing functional and social problems. The course of frontotemporal dementia is not modifiable as of now with existing treatment options at present, but we are hopeful in future for the therapeutic options for frontotemporal dementia. Thank you for your patientful hearing.
Thank you, ma'am. Before inviting to the next speaker, my question to Dr. Suman, just a query because lot of residents are also here. It is although very difficult to differentiate between the behavioral variant of AD and FTD in the initial stage, But is there any clinical history from history point of view? Some points can we differentiate behavioral variant of AD with FTD in the early stage?
Sorry, behavior variant of ATD, behavior variant of AD versus the behavior variant of AD versus FTD is really challenging to distinguish, but there are some markers like disinhibition and apathy are the two symptoms which are very common with FTD, while suspiciousness and depression are the common profile in the patients of AD. So it is like we have to be very categoric in differentiating. It is although very difficult, but some are like disinhibition is more common in patients of FTD.